Welcome to Exercise Science 4700 UVU. Today we are doing the special tests of the ankle. To begin this, we have already got permission. I have permission to touch my ankle and to stress test it to see if there's any pathologies going on or interpret why, if they are. We're going to start with active range of motion. Fairly simple. We're going to have the client, you'll ask them first of all, you want to examine their shoes, and we've already talked about that. You will have watched them walk in and you've done a visual assessment. Now you will have test the dorsiflexors. Any muscle that passes anterior to a medial lateral axis, please dorsiflex. Have them walk on the heels. Now demonstrate how your calf muscles work and by walking on your toes. So have them up on their toes. Okay? And then we want to see how the muscles that turn the foot in work. They're inverters. This is anterior tib, extensor hallucis longus, Tom, Dick, Harry. So walk on the outside of your feet and we are inverting. The everters are anything lateral to an anterior posterior axis. This is extensor digitorum longus, not the extensor digitorum brevis because it originates down in the tarsals. It doesn't cross the ankle. But the proneus, tertius, brevis, and longus do. And they will pull the foot out, the sole of the foot, walk on the instep of the foot. If your client is not able to do that, then we're going to go ahead and do some passive range of motion tests. Now watch closely in Hoppenfield. He does a good job of describing these tests, specifically important because a lot of compensation can take place in the ankle when testing these motions. Again, we want dorsiflexion. The person will be sitting on the table relaxed with their legs dangling. You'll pick it up and control it you're cupping the heel of the foot, and by putting the foot into a slight inversion, I'm going to slightly invert and plantar flex the foot. This inversion locks the talus, locks the tarsals into each other so we don't get substitution motion. Okay? Just a minute, I need to close the door. So we don't substitute motions. It locks it into the mortise. So we're going to slightly invert. And now with my hand, I'm going to move the forefoot up into dorsiflexion. And likewise down into plantar flexion. For passive range of motion, cupping the heel. For inversion, I want to isolate the tarsals. Hoppenfield very well, he points out that dorsiflexion and plantar flexion occur at the talotibial joint. Note, inversion and eversion occur in the tarsals, referred to as subtalar, from the talus down. Forefoot adduction and abduction, A2-4, occur at the tarso-metatarsal joints. And when you do supination, which is a combination of inversion and forefoot adduction, we have foot supination. If it went far enough, you could hold soup in it. And a combination of eversion, subtalar, and forefoot abduction is pronation of the foot. Palm down, the arch is going down. So do be aware, I will not hold you for degrees of movement, but I will hold you for what joints they take place in. One of your teammates just mentioned, I called this metatarsus calcaneal primus. Well, you'll notice that this is why I bring it up. It's significant. The first metatarsal doesn't even articulate with the calcaneus. It's with the first cuneiform. Curious that the navicular articulates with the talus and the first three cuneiforms, and the calcaneus articulates with the talus and the cuboid. Hoppenfield makes a point of that, and that is clinically significant. So we've done dorsiflexion, plantar flexion. We're going to stabilize with the person's foot here, the tib fib, and then grabbing either from here, or if they're at the end of the table here, and isolating the distal tib fib, we're going to move the tarsals on the tibia and fibula. Mostly subtalar, because the talus is locked up into the mortise. Again, this is where you want to do a slight inversion of the foot and plantar flexion, and then you can isolate inversion versus eversion. To isolate forefoot adduction and abduction, we're going to go to the proximal segment of the metatarsal phalange joint. So the distal tarsals, and then with the palm of your hand, you can move the foot into adduction, the forefoot, abduction, A24, or adduction towards the medial line or the great toe. Those are the active range of motion and the passive range of motion. For manual muscle test, that's where your quadrant homework comes in very handy. I want to test, and generally in the body, we are testing groups. Please demonstrate knee, kick your foot up, it's called knee extension, and I'm testing the quads. There's 4 muscles in that. Excuse me. With the foot, we can actually isolate down to a specific muscle because of where they cross the medial lateral and anterior posterior axis. Part of your quiz today demonstrated that. If you'll lose your sock, please, and look at your own foot, it looks the same as this, except this doesn't have skin, as you've noticed. But here we have an anterior posterior axis, and anything that passes medial to that is going to pull this way, so we have inverters. Extensor hallucis longus, not by much, but it does. Anterior tib, posterior tibialis, flexor digitorum longus, Tom, Dick, Harry, flexor hallucis longus, are all medial to an anterior posterior axis. So if we want to test specifically manual muscle test as our part of our neurologic examination, we're going to generalize dorsiflexors as L4 nerve root. They do branch into L5, but primarily L4. Your primary dorsiflexor is the anterior tibialis. It's the strongest. Then the extensor hallucis longus and the extensor digitorum. All 3 make up the anterior compartment. Dorsiflexion is L4. Plantar flexion is S1. We're not going to give a number to the perineals or the inverters or the everters. So if I want the anterior tib, it's the primary inverter and dorsiflexor attaching to the anteromedial quadrant. Have the person bring your toes up and into my hand, and they'll point their toes up, and that anterior tib will really stand out. Then you can stabilize the distal segment here and apply your 0 to 4 resistance. If you want to isolate the extensor hallucis longus, go into more neutral, pure dorsiflexion without the inversion. That takes the anterior tib out a little bit, and it isolates the extensor hallucis longus. Have them dorsiflex, and then you resist their, wow, excuse me, you resist their great toe and take it into flexion for your manual muscle test. By itself, according to Hoppenfield, but actually peroneus tertius ties down in anterior, it's a dorsiflexor. You can isolate the extensor digitorum longus. Dorsiflex, it's lateral to an anterior posterior axis. So dorsiflex and evert targets more of this muscle group. And then you can resist them holding their toes up as you curl them down for manual muscle testing of that specific muscle. With the peroneals, we can do the flexor hallucis. It's posterior, so it's a plantar flexor. It's medial, so it's an inverter, and it ties into the toes. Have them plantar flex, invert, and curl the great toe. You can do it on your own foot right now. Plantar flex, invert, curl the great toe. You'll see it stand out, passing inferior to the medial malleolus, and then resist it, and you can test that muscle. Same thing with the flexor digitorum longus. Have them flex the toes, and you can resist the toe flexion. And the flexor hallucis longus, the posterior tib is the primary inverter. So without flexing the toes, if you can, the great toe or the other four, have them just plantar flex and then resist on the ball of the foot right here. Point down and in. Don't curl your toes, and then you're really isolating the anterior tib. Manual muscle test. L4 for dorsiflexion. No. Yes, L4 for dorsiflexion, S1 for plantar flexion. I'm questioning myself because the extensor hallucis longus is L5 and the digitorum is L5, but the anterior tib is L4, which is drop foot. Okay, sensation, because the dermatome crosses the knee and down the medial leg and the medial foot, L4, medial foot. L5, dorsum of the foot. S1, lateral foot. And a part of the posterior calf is S2. That is sensation. 4, 5, S1, S2. Motor, 4, S1. Reflex. For the reflex, you can have the person seated, dangling their legs. You'll have the hammer, have them just relax. The foot will naturally plantar flex and invert a little bit. With the palm of your hand, put a slight tension on the tendon, the Achilles tendon. That enhances the Golgi tendon organ, or the stretch reflex. You'll palpate the Achilles, and Hoppenfield has good diagrams and explanation here to get the borders, and often your reflex hammer will have a broad side. Since it's a broad tendon, put it on slight stretch, and then you'll tap right on the tendon, not up in the belly of the muscle, but down where you felt the you didn't feel it, but you're on the retrocalcaneal bursa, and give it a quick pop right there. You don't get much as powerful as that muscle group is, but all you'll do is, you may not even see it, but you'll feel a little plantar flexion press in the hand where you are forcing a dorsiflexion. So you'll smack it here and you'll get a little forefoot plantar flexion. And that's normal versus hyper and hypo. For the reflex, and the reflex is designated S1. Special tests for the foot. You'll see people at times who toe out or toe in when they walk. That might be an anteversion or retroversion in the hip. We're going to dance here. This angle between the head, the neck, and the femur can be tipped one way or another, anteversion and retroversion. That can cause a toe in or a toe out. It can be a tight hip internal rotator, can cause toe in or toe out. More often than you'd think, it's a torsion of the tibia. The tibia is twisted. To assess that, we're going to do a tibial torsion test. It's quite accurate. In the quiz today, we talked about the medial malleolus is slightly anterior of the lateral malleolus. It is actually a 15-degree angle. If 12 o'clock or 0 is straight out the great toe, we have an angle of 15 degrees out this way with the line between the two bones. You can see here that's about 15 degrees. That is normal. But the whole tibia might be turned out. So what we do is you will expose the tibial tuberosity. Osgood-Schlatters disease, you put a mark on it. Remember where we put a marker on the patella and a marker on the tibial tuberosity to see if the patella is tracking right, or if it's squinting, staring at its twin sister, or patella looking outwards. See if it's lined up. A mark on the tibial tuberosity, and if that tuberosity, you'll adjust the leg, the tibia, so the tibial tuberosity is straight at you or vertical. You can be here with it coming straight at me, or the mark vertical. And then I want this angle to be about 15 degrees. With it lower on the lateral malleolus and higher on the medial, we talked about that, and then 15 degrees this way. With the tibial tuberosity straight forward, we're going to have this angle here. That is normal. If it's more than that, the toeing in is coming from a tibial torsion twisting upon itself. If the tibial tuberosity and these are both like this, then it's not in the tibia because they've got the proper relationship. Very well. Tibial torsion. We have another test called Hohmann's sign. This is to test for DVT. I used it on myself back in 2010, and it likely saved my life. On a Friday, I felt a pain back in the popliteal space. That's strange. There's no mechanism for a strain of any kind or a sprain. I did a few tests. I did the Hohmann's sign. It was all negative. I'm going to have to run it and watch it. That's what a mechanic says when they don't know. Let's run it and watch for more signs and symptoms. It's what an orthopedic says when we don't know. So I'm going to run it and watch it. This was like on a Monday. It went through the week, and then the next Monday, and it got worse and worse. But the tests were negative for anything. There was no mechanism for it. The next Monday, I woke up and I took my first few steps in the morning, and my calf was throbbing. I could feel my pulse in my calf. I'm thinking, great, this is vascular. I can feel my pulse because there's so much pressure, just like when you smash your thumb. Your thumb is throbbing. Every time your heart beats, it's trying to surge arterial blood into the thumb. It's already taken up with swelling and hematoma, nowhere for it to go, so it puts pressure on the nerves every time your heart beats. I could feel my heartbeat throbbing in my calf. So I did Hohmann's sign, and it was positive. Great, I don't have time for this. Grades were due. It's Monday after December finals on Friday, etc. But that's another story. But anyway, I did get a positive Hohmann's sign. With Hohmann's sign, you're going to have the person relaxed, and you're suspecting a DVT, deep vein thrombosis. With that condition, there's a blood clot in the tibial vein, posterior tibial vein, or one of the veins in there. And blood is entering the lower leg, but it can't exit very well. And so the leg will start to swell. That's a symptom. It's tough to tell with the eyeball test, the EBT, so you'll need to take girth measurements at different locations, comparing bilaterally. You may, like anterior compartment syndrome, it may start to get shiny white because the skin is being removed from the blood supply, so it's not as pink or whatever the pigment is. And you might start to see redness down in the foot because it'll start to get inflamed. With me, it was the pain back here. I didn't notice swelling, but I could feel the throb, so I knew I had swelling, so I administered Hohmann's sign. With the leg relaxed, you're going to put find right in the middle of the two heads of the gastrocs and press deep up. No, you're gonna have the leg out straight. Now, I get a positive Homan sign anytime, even now, because I have very tight hamstrings. They're a two-joint muscle. They cross the knee. They do flexion. If you do extension, it puts them on tension. And they cross the hip as extensors. If you do hip flexion, now right there is uncomfortable to me. With a straight leg doing this. That's a positive Homan sign. Pain in the calf and the hams. I prefer the little addition that Hoppenfield adds after you put the plantar flexors on stretch. Dorsiflex the foot. That's Homan's sign, and it'll create pain in the calf. But you can all understand if somebody's tight in the plantar flexors and you dorsiflex it passively, it might be painful. Now the extra part is to push up between the two heads of the gastrocs. Probe deep up into the calf, and if that creates neurologic or vascular symptoms, a deep ache more than the non-involved leg, different, weakness, pain, tingling, ache, numb, or with vascular, it's more of an ache or a throb, and that's what I felt that morning. Yep, this is positive. I've now got to go into the ER. So, went in, and sure enough, I danced into the ER. What's the matter? Oh, I've possibly got a DVT. I'm not even limping because it wasn't that bad, but it was real. Possible DVT to the triage nurse. Oh, and I've been short of breath lately. You better check me for a PE because I may have thrown a clot. Pulmonary emboli goes to the right heart. Veins are getting bigger, so it's not going to get stuck. Goes to the right atrium, fine to the right ventricle, out to the lungs, and then the vessels get smaller until they're small enough that clot can't pass through anymore. I've had several first cousins who stood up and said, I don't feel well, and they were dead before they hit the ground with the PE. When the doctor, they did an ultrasound of my leg. This is way above and beyond. It ought to be on the different recording. I'll have to edit it, but I probably won't. They're doing ultrasound, and all of a sudden, they're rushing me in for a CT scan and filling my lungs full of dye and stuff, and rushing me down and shooting me up with all kinds of blood thinners. Wait, what's going on? Has nobody said anything? No. Well, you've got a DVT from here to here, and you've got a shotgun blast of pellets throughout every lobe of your lungs. We don't know why they broke up into little teeny pieces. It saved your life because it wasn't a primary PE that closed off the entire lung. But for some reason, it broke up into a shotgun blast, and there's little clots all over in your lungs. That saved your life. Well, I know why it happened, because I wanted to be here in this class today telling the story. Happy to be here. So, Homan's sign. With a youngster, you may see the forefoot really bent in, forefoot adduction. You can stabilize the heel, and you should be able to push the forefoot back to neutral. When you're playing with this little youngster and you're pumping the legs and you're doing Ortolani click and you're doing the hip abduction test, etc., posterior telescoping test, and the parents don't know, have a clue what you're doing, you'll look at the feet and they'll likely be forward. You can pin the calcaneus and then touch it forward and it'll go back to neutral. That's normal. Walking and weight bearing will return it to a normal position. If it's rigid and will not go back, then there might be a problem, but don't freak the parents out. Say, you know what? My training says that I should be able to push the foot back a little bit. This isn't a medical emergency. In the next month, I'd get it to the pediatrician and see what they think. Okay? Another test, we have talked about it elsewhere, is rigid versus rigid, flat foot, and, wow, the term left me. Supple, thank you, rigid and supple. We are over on page 232, rigid and supple. If a person has flat feet, when they are not weight bearing, the head of the talus is collapsed down, and they have flat feet when they are weight bearing, it's structural, it's rigid, it's not going to change, it requires surgery. If they have flat feet when they're weight bearing, but then they become open kinetic chain or not weight bearing, and the arch goes back, that tells you it's the weight that's doing it. Soft tissues are weak, so the weight is pushing through them. The spring ligament's not doing its job. The posterior tibialis, the peroneus longus, the aponeurosis. Anyway, they're weak. It's supple, rigid versus supple. Supple is soft tissue. As a therapist, I can make changes, or an orthotic can fix it, and we can strengthen it. If it's rigid, it's bony, it's going to require surgery. Okay, and tibial torsion, and reflex, and dermatomes, and manual muscle tests, and active and passive range of motion. That is the assessment of the special tests of the ankles. I'll end the one video. I kind of apologize for the personal medical history, but it's a great lab of life lesson, so it's good application for this situation. Homan sign, personally, just like the patellar compression test or Finkelstein sign, I think they hurt for anybody. We've not done that because we haven't done the hand. Likewise, Homan, if you've got tight hams like me or plantar flexors, that's a positive test when it's not really positive. Make sure you test it bilateral. But I call Homan sign when you include probing up between the two heads of the gastrocs, proximal towards the knee. That's when I got the positive sign. But the thing that got my attention was the throbbing. I pointed out in soft tissue assessment, after all of the inflammation and swelling went down, lots of blood thinners, etc., I noticed a lot of varicose veins here. And when I approached the doc, he said, yes, because the blood clot had so much pressure back behind it, it blew out the valves in the veins. Remember, it's like a fish ladder. Arteries, the heart pumps blood from the heart to the extremities one way. It doesn't pump it back. It's you moving that squeezes the tissues, that pushes the blood up the vein. When you relax, it tries to backtrack. The valve flaps shut, one-way valve. Well, the valves break down, so now blood is pooling here, and you can see the varicose veins in my foot. It has not progressed in 11 years. It's the same. Anyway, another lab of life situation. Okay, I will end this recording, and we'll come back to the class recording.